Hello everybody and welcome to our module on other vitamins. In this module we're going to talk about the non-B vitamins. Those are vitamins A, C, D, E, and K, and most of these are fat soluble. The only exception is vitamin C. If you look down at the bottom of the screen on the left-hand side is the chemical structure of vitamin A. You can see that other than this one oxygen molecule, it is entirely composed of carbons and hydrogens. And structures composed of carbons and hydrogens are not water soluble but are soluble in fat. Same is true of vitamin D. If you look at its structure, other than this one OH group here, everything is carbon and hydrogens. Therefore, it is going to be fat soluble and not water soluble. And this is in contrast to the B vitamins. All of the B vitamins are water soluble. Because these vitamins are fat soluble, there's a special way by which they are absorbed in the GI tract. Together with other lipids, fat soluble vitamins form structures called micelles in the jejunum. Micelles are clusters of lipids arranged so that the hydrophobic portion of any lipid or fat-soluble vitamin will be towards the inside and the hydrophilic portion will be towards the outside. This is a picture of a micelle on the screen here. The hydrophilic portions are on the outside and the hydrophobic portions are on the inside. Lipids and fat-soluble vitamins have some parts of the molecule that, like water, those parts are called hydrophilic. They go towards the outside. So for example, the oxygen part that we saw on vitamin A on the last slide might be situated towards the outside in a micelle. The carbon and hydrogen parts are hydrophobic and they are all pushed towards the middle in micelles. These micelles are absorbed by enterocytes and packaged into chylomicrons. The chylomicrons are secreted into the lymph, and then the lymph carries the chylomicrons to the bloodstream and then the liver as chylomicron remnants. And I talk about this in more detail in the modules on lipid metabolism. There are a number of clinical conditions that result in fat malabsorption, and if you develop one of these conditions, you will become deficient in the fat-soluble vitamins A, D, E, and K. Basically, to absorb the fat-soluble vitamins, you need normal bile, normal pancreatic secretions, and a normal intestine. So if you have a disease that affects your production of bile or pancreatic secretions, you can develop fat malabsorption and become deficient in these vitamins. Additionally, if you develop disease or have a resection of your intestine, you can also be unable to absorb vitamins A, D, E, and K. And there are a number of causes of fat malabsorption, but I've listed some of them on the screen here. Cystic fibrosis can result in lack of pancreatic enzymes, and this can lead to fat malabsorption. Celiac sprue can affect the intestinal absorption of vitamins A, D, E, and K. You can also become deficient in fat-soluble vitamins from Crohn's disease, primary biliary cirrhosis, and primary sclerosing cholangitis. The first vitamin we're going to talk about is vitamin A. Vitamin A is also called retinol. This is the structure of retinol on the screen, and you can see that it's almost entirely carbons and hydrogens, and therefore it should make sense to you that it is a fat-soluble vitamin. Retinoids are a family of structures that are derived from vitamin A, and they are important for vision and growth and epithelial tissues. In fact, because they're important for vision, they are named retinoids because they affect the retina of the eye. And some of the key retinoids that we're going to discuss in this module are retinol and retinoic acid. Before we talk about the retinoids, I want to talk about a very important dietary source of vitamin A, and that is beta-carotene. Beta-carotene is a structure called a carotenoid, and it is pro-vitamin A. It's the major source of vitamin A in our diet. This is the structure of beta-carotene on the screen, and you can see it almost looks like two vitamin A molecules linked together. And it can be cleaved and used to synthesize retinal, and from retinal you can derive other retinoids. Beta-carotene, in addition to being a source of vitamin A, has antioxidant properties by itself. This is similar to vitamin C and vitamin E, which we'll talk about later in this module. Beta-carotene, vitamin C, and vitamin E are all antioxidants, and they protect against free radical damage inside tissues in the body. And there is some evidence that these vitamins and beta-carotene may reduce the risk of cancer and other diseases. This is the structure of retinal on the screen here. It's one of the important retinoids, and it is found in visual pigments. It's used by the rods and cones in the retina of the eye. There is a protein in the eye called rhodopsin, which is light sensitive. It generates nerve impulses based on the type of light that interact with the protein, and it contains retinol, and that's why you need vitamin A in order to have normal vision. Shown on the screen is the structure of retinoic acid. Retinoic acid is responsible for many of the non-visual functions of vitamin A. Retinoic acid works by acting like a hormone. It binds to receptors in the nucleus of cells, and it regulates or controls protein synthesis. And in the literature, you can find many examples of the effects of retinoic acid on protein production inside of different cell types. One important example that's worth knowing has to do with keratin. You may know that keratin is a structure necessary for the maintenance of healthy skin, and retinoic acid can limit or control keratin production in skin tissue. If you know this, it will help you remember that retinoic acid or similar structures are often used in the treatment of different skin disorders, including psoriasis and acne, and we'll talk more about that a little bit later. This effect on keratin also explains why patients who are deficient in vitamin A can develop dry skin. And then another important example to know about has to do with mucus production. Retinoic acid can limit or control mucus production in many different types of epithelial cells in the body. Vitamin A is found in liver. It's also found in dark green and yellow vegetables. Unfortunately, very few people eat liver, and a lot of people underconsume dark green and yellow vegetables. So there are probably many people who don't get enough vitamin A in their diet. It's stored in the liver, however, and it takes years to develop deficiency, and deficiency is relatively uncommon. Now that you know some of the roles that retinoids play inside the body, it's easy to understand what happens when you're deficient in vitamin A. First of all, you can develop visual symptoms. One of the first signs that often develops is night blindness. This is the picture of a night sky here. You can see that there is very little light, and you need well-functioning retinas in order to be able to see the stars and see in the dark. If you're deficient in vitamin A, one of the first things that happens is when you go out at night, you feel like you are blind because you can't see in the low light environment. Another finding of vitamin A deficiency is called xerophthalmia. This is keratinization of the cornea, and this can lead to blindness. Other symptoms of keratinization also occur in the skin. Patients can develop thickened, dry skin. And then finally, children who are deficient in vitamin A can develop growth failure. Vitamin A is used as therapy for a number of medical conditions. The first one is measles. Measles is very rare in the United States because of immunization. This is a picture of a child with measles on the screen. The mechanism of its benefit is unclear, but it's used as a therapy in resource-limited countries because vitamin A is relatively cheap and easy to administer. In addition, as I told you before, vitamin A is used as a treatment for some skin disorders, including psoriasis and acne. There's one type of leukemia that is sometimes responsive to vitamin A, and that is AML, the M3 subtype, which is also called acute promyelocytic leukemia. Patients with this condition are sometimes treated with all-trans retinoic acid. It's also called ATRA or tretinoin. This is a synthetic derivative of retinoic acid, and it induces the malignant cancer cells to complete differentiation. As a result, they become non-dividing mature granulocytes or macrophages, and the leukemia can resolve. This is a picture of a biopsy specimen of someone who has the M3 subtype of AML. The classic finding is an hour rod, and there's one shown on the screen here. As we will see in this module, most of the non-B vitamins have a syndrome that can develop if you consume excess vitamin, and this usually happens from taking too much supplements. In the case of vitamin A, the syndrome that develops is appropriately called hypervitaminosis A. This is usually from chronic excessive intake of vitamin supplements. What happens is these patients develop dry, itchy skin, and they can develop an enlarged liver because, remember, vitamin A can be stored in the liver. There is a treatment for acne called isotretinoin. It goes by the name Accutane, and this is a derivative of vitamin A. The structure is called 13-cis-retinoic acid. This is a picture of its structure on the screen here. You can see that it's very similar to some of the other retinoids we've been discussing, and it's very effective for the treatment of acne. The problem is it's highly teratogenic, so women who are taking this, who are of childbearing age, usually need to be placed on oral contraceptive pills so they don't have an accidental pregnancy, and often they are also pregnancy tested prior to beginning therapy. Our next non-B vitamin is vitamin C, which is also called ascorbic acid. This is the only water-soluble vitamin among the non-B vitamins. This is the structure of vitamin C on the screen. You can see it has lots of oxygen molecules, and these will make it soluble in water, and that's different from the other fat-soluble non-B vitamins. Just like we discussed before for beta-carotene, vitamin C has antioxidant properties. It can protect against free radical damage, and there's some evidence that it may reduce risk of cancer or other diseases, although this has never been definitively shown in clinical trials. You can find vitamin C in fruits and vegetables, and it has three key roles in metabolism that we'll discuss. The first one is absorption of iron, the second one is collagen synthesis, and the third one is dopamine synthesis. There are two ways by which you consume iron in your diet. The first way is in the form of heme. This is a picture of a molecule of heme like you would find in hemoglobin, and you can see that it has iron in the center of it. And lots of the iron you consume in your diet is in the middle of molecules of heme just like this, especially when you eat meats. And this type of iron is easily absorbed by duodenal epithelial cells. The other way you get iron in your diet is as non-heme iron, and this is where you need the help of vitamin C. Lots of the non-heme iron that you consume is in the Fe3 plus state, and this cannot be absorbed. Vitamin C converts Fe3 plus iron into Fe2 plus iron, and that Fe2 plus iron can then be absorbed by duodenal epithelial cells. And this is especially important for vegans. They don't consume much meat, so they get very little heme iron. So they need to take enough vitamin C so that they can absorb all the vitamin in the Fe2 plus state. You may know of a medical condition called methemoglobinemia. This occurs when a drug or something else converts much of the iron in heme to the Fe3 plus state, and it can be life-threatening and dangerous. And one of the treatments for methemoglobinemia is to administer vitamin C, and that's because vitamin C will convert the Fe3 plus iron in heme back into Fe2 plus iron. So it's very useful to remember that vitamin C is important for the conversion of Fe3 plus iron to Fe2 plus iron. The second role of vitamin C is actually related to iron absorption, and that is collagen synthesis. Vitamin C is very important for the post-translational modification of collagen. You don't need it to synthesize collagen, but if you want to modify collagen into an effective structure, you need vitamin C to help. What vitamin C aids in doing is hydroxylating specific proline and lysine residues on collagen. Proline and lysine are amino acids, and they are found in collagen molecules, and they need to be modified by vitamin C in order for the collagen to be fully effective. This occurs in the endoplasmic reticulum, and this means that if you are deficient in vitamin C, you will have underproduction of collagen, and this can lead to scurvy, which we'll talk about later. If you look at the bottom of the screen here, I've shown you the structure of the amino acid proline. Proline can be converted into hydroxyproline, and this is done as part of the synthesis of collagen. In order to do this, Fe2 plus iron gets converted to Fe3 plus iron, and then you need vitamin C to convert it back, just like we saw in the last slide, for absorption of iron in the gut. Vitamin C carries out this role for proline residues and lysine residues on the end of collagen molecules, and if you don't have enough vitamin C, you won't get enough collagen synthesized, and then you will develop scurvy. The final role of vitamin C involves synthesis of neurotransmitters. The amino acid tyrosine is used to synthesize dopamine, and from dopamine, you can make norepinephrine using an enzyme called dopamine beta hydroxylase, and this enzyme requires vitamin C. The clinical syndrome that develops if you're deficient in vitamin C is called scurvy, and the symptoms are due to defective collagen synthesis. Patients with scurvy develop sore gums and loose teeth. Their teeth can fall out. They have fragile blood vessels from lack of collagen, and this can lead to easy bruising. Scurvy is a very important disorder from a historical perspective. It was very common on long sea voyages. On long sea voyages, sailors would not get any fruits and vegetables, and they would develop scurvy, and they would often die. As a result, when sailors were at port, they would eat lots of limes, which contained vitamin C. And this is why you will sometimes see old movies where they call pirates or sailors a limey, and that's because those people were always eating limes to try and stock up on vitamin C before they went out to sea for a long period of time. It's also seen in so-called tea and toast diets when people are trying to lose weight. They don't eat any fruits and vegetables, and scurvy is possible. There is a syndrome that can occur if you consume excess vitamin C. It has nonspecific GI symptoms like nausea and vomiting and diarrhea. The things they will want you to know about this for step 1 include that it can cause iron overload. As we saw before, vitamin C leads to absorption of iron, and if you are predisposed to iron overload, for example, if you have hemochromatosis or frequent blood transfusions, then consuming too much vitamin C can worsen the iron overload syndrome. Another problem that occurs from vitamin C excess is kidney stones. Vitamin C can be metabolized into oxalate, and therefore people who consume too much vitamin C can develop calcium oxalate kidney stones. Smokers have an increased vitamin C requirement, and this is likely because vitamin C is consumed as a result of its antioxidant properties and the role it probably plays in fighting off oxidative damage from smoking. When vitamin C levels are measured among smokers, deficient levels are common. Symptoms of scurvy, however, or symptoms from the vitamin C deficiency are relatively rare. Our next vitamin is vitamin D, and vitamin D is found in 2 forms in the diet. The first one is called vitamin D2 or ergocalciferol. This is the structure of vitamin D2 on the bottom of the screen. You can see that it is almost entirely made up of carbons and hydrogens, and therefore it's going to be a fat-soluble vitamin. And you can find vitamin D2 in plants. Vitamin D3 is called cholecalciferol. This is the structure of D3 on the top of the screen. It looks almost identical to D2, except this one carbon has been removed in vitamin D3 or cholecalciferol. D3 is the more active form of vitamin D. It's the form that is added to fortified milk. It's the form that nutritionists recommend you take as a supplement. And there are 2 ways you can get vitamin D3, either from the diet or from the sun. Sunlight can be used by the body to synthesize vitamin D3 from cholesterol. Once vitamin D3 is present inside your body, either from the sun or from food, it will be inert. It has no biological activity. In order for it to become biologically active, it must be hydroxylated. This means OH groups must be added to the molecule, and it has to go through two hydroxylation reactions in order to become active. The first hydroxylation occurs in the liver. This is called 25-hydroxylation. This is the 25 carbon on the vitamin D3 molecule, and therefore an OH group will be added to this carbon, and that will be a 25-hydroxylation reaction. As I said before, this occurs in the liver, and this is not under any type of hormonal control. It's constantly occurring. Anytime D3 is consumed in the diet or synthesized from sun exposure, the liver will hydroxylate it as soon as it gets the opportunity. The second hydroxylation is called a 1-hydroxylation. That occurs at the 1 carbon on the vitamin D3 molecule. This occurs in the kidney, and this is regulated by parathyroid hormone. What this means is that you're always going to have a lot of 25-hydroxylated vitamin D3 floating around in your body, and the kidney is going to selectively hydroxylate it at the 1 position as it needs to in order to activate more vitamin D to do its job. So just to summarize these points, the liver converts D3 to 25-hydroxyl vitamin D, which is called calcidiol. The kidney converts vitamin D3 to 125-OH2 vitamin D, which is called calcitriol. And 125-OH2 vitamin D is the active form. As I said before, 25-OH vitamin D is the storage form. It's constantly produced by the liver, and it's available for activation by the kidney as needed. This is important clinically because when you want to check someone's vitamin D status, what you measure is the serum concentration of 25-OH vitamin D. It has a long half-life, the liver production is not regulated, and this is the storage form, so you will detect how much storage form of vitamin D that patient has in their plasma. The final hydroxylation to the active form of vitamin D is the 1-hydroxylation, and that occurs in the kidney, as I said before. Specifically, it occurs in the proximal tubule, as I've indicated in this picture on the screen. The proximal tubule cells convert 25-OH vitamin D to 125-OH2 vitamin D using an enzyme called 1-alpha hydroxylase. And this enzyme can be activated by parathyroid hormone, and that is the way by which parathyroid hormone influences the amount of active vitamin D inside of the body. It's important to know that this hydroxylation at the 1 position can occur independent of the kidneys in some conditions, especially sarcoidosis. The macrophages in sarcoidosis can activate vitamin D independent of the kidneys, and this can lead to hypercalcemia, which is often seen in sarcoidosis. Vitamin D has effects in the GI tract and in the bones. In the GI tract, it increases the amount of calcium and phosphate absorption. This raises the calcium level, and because there's more calcium and phosphate available, this will lead to increased bone mineralization, and you may know that vitamin D is important for healthy bones. In the bones, vitamin D can also stimulate the resorption of calcium phosphate from bones. This is good for raising your calcium and phosphate level, but it's bad for the bones because it can lead to demineralization. And this can be a point of confusion for students. How can vitamin D be good for bones in one case but bad for bones in another? The thing you need to understand is that these effects on bones are a paradoxical effect, and they only occur at abnormally high levels. At normal physiologic levels, the major mechanism of vitamin D's effect is in the GI tract, not in the bones. And this is what you see at normal physiologic levels as the amount of active vitamin D goes up and down. There's a nice review article at the bottom of the screen here if you want to read more about this paradoxical effect of vitamin D on bones. If you are deficient in vitamin D, you will have poor absorption in the GI tract of calcium and phosphate. This can lead to low phosphate levels and also to low calcium levels, and sometimes in vitamin D deficiency, the symptoms of hypocalcemia can develop, including tetany and seizures. The bigger problem in parts of the world where people are malnourished and chronically deficient in vitamin D is that they have poor mineralization of their bones. In adults, this manifests as a condition called osteomalacia, and in children, this manifests as a condition called rickets. Osteomalacia occurs in children and adults when they're deficient in vitamin D, and it occurs in areas of bone turnover. You need to understand that your bones are not static. They are constantly being remodeled. There are osteoclasts that clear bone away and osteoblasts that lay down new bone called osteoid. If you're deficient in vitamin D, you will have poor mineralization of the newly formed bone, and the clinical features that will develop include bone pain and tenderness and a high rate of fractures from that weak bone that's being laid down due to vitamin D deficiency. Patients with osteomalacia have very high levels of PTH. The body is trying to activate all the vitamin D that's available, but there just isn't enough available. And if you take a chest x-ray of patients with osteomalacia, you will see that the bones are relatively pale and not bright white as they should be. This is described as reduced bone density. Rickets is a clinical syndrome that occurs in vitamin D deficiency only in children, and the reason it only occurs in children is because it involves deficient mineralization of the growth plate, and as you may know, only children have growth plates in their bones. There are a number of processes going on in children at the growth plate. Chondrocytes are hypertrophying and proliferating, and then vascular invasion is occurring, and these new blood vessels bring in calcium and phosphate, and that leads to mineralization. When you don't have enough vitamin D in a child, the growth plate will thicken, the chondrocytes will hypertrophy and proliferate, but it won't mineralize. As a result, you get very weak and abnormal growth plates. The clinical features are bone pain, and the distal forearm and knee tend to be the most effective because there is rapid growth in these areas. The skull may show delayed closure of the fontanelles, especially in a baby, and then a classic X-ray finding is bowing of the femur and tibia. This is a picture of a child with rickets. You can see that the legs are bowed. They are also relatively pale and not bright white, and that's because they have low bone density from vitamin D deficiency. Vitamin D plays an important role in renal failure. Patients who have sick kidneys cannot excrete phosphate, so they develop hyperphosphatemia. In addition, they cannot perform the final activation step in vitamin D activation, so they have low levels of the active form of vitamin D. High levels of phosphate in the plasma lead to low calcium in the plasma because phosphate can bind calcium. In addition, because you have low levels of the active form of vitamin D, you decrease the amount of calcium absorbed from the gut. Both of these processes lead to hypocalcemia, and the hypocalcemia stimulates the parathyroid gland, and that leads to elevated levels of PTH. And all of these are classic findings in patients who have renal failure. Natural sources of vitamin D include oily fish like salmon. If you eat liver, you'll consume lots of vitamin D, and you can also find it in egg yolks. In the United States, most milk is fortified with vitamin D, and this was done to eliminate rickets many years ago. Rickets used to be relatively common. Because milk contains calcium, they fortified it with vitamin D, and therefore if you drink milk, you will get plenty of vitamin D and plenty of calcium, and you should not get rickets, and that's why we almost never see rickets anymore in the United States. Babies who are being breastfed are particularly vulnerable to low levels of vitamin D, and that's because breast milk is low in vitamin D even if the mother has sufficient levels. It turns out that women who have dark skin have even lower levels of vitamin D in their breast milk. In addition, most infants get very little sun exposure, so they're not going to synthesize much vitamin D from cholesterol. This means that babies that are being exclusively breastfed need to have vitamin D supplementation because they are at risk for symptoms of low vitamin D. If you have too much vitamin D in your body, you develop a syndrome called hypervitaminosis D. This can very rarely occur from massive consumption of vitamin D supplements. The other situation where it's sometimes seen is in sarcoidosis. The granulomatous macrophages in sarcoidosis express 1-alpha hydroxylase, and as I told you before, they can activate vitamin D independent of the kidney and parathyroid hormone, and this can lead to high levels of active vitamin D. If you have too much active vitamin D inside of your body, you will get too much of the things that vitamin D does. You will have hypercalcemia. This will lead to hypercalciuria, meaning lots of calcium in the urine, and this can cause kidney stones. And then the high levels of calcium can often lead to confusion. Our next vitamin is vitamin E, which is also called tocopherol. This is its structure on the screen. You can see that it's almost entirely carbons and hydrogen, so it's going to be a fat-soluble vitamin. The main role of vitamin E is to serve as an antioxidant. There is evidence that it protects against oxidative damage. It probably has a key role in protecting red blood cells from oxidative damage because, as we will see, when you are deficient, you can develop an anemia. Vitamin E deficiency is very rare. The anemia that develops is a hemolytic anemia, and this is probably because red cells lose the antioxidant protective effects of vitamin E. In addition, patients can develop muscle weakness and ataxia and loss of proprioception and vibration. Now, one thing you need to be aware of, especially for the boards, is that ataxia and loss of proprioception and vibration can also occur with a vitamin B12 deficiency. In addition, you can get an anemia. It's a megaloblastic anemia, but you can get an anemia in B12 deficiency as well. The things you want to watch out for to know that you're dealing with a vitamin E deficiency is a hemolytic anemia and also the muscle weakness. The muscle weakness is usually not a feature of a vitamin B12 deficiency. Sometimes it involves the eyes because the eyes have very small muscles and they are sometimes the first to develop the symptoms of weakness. So symptoms of diplopia may occur in someone who is vitamin E deficient, and that will tell you that it is not a vitamin B12 deficiency question. As we have seen, most of the fat-soluble vitamins have a toxicity syndrome if you consume too much. Vitamin E is the least toxic of all the fat-soluble vitamins. There really isn't a very important syndrome associated with consumption of too much vitamin E. There are some reports that patients who take very high dosages have inhibition of the effects of vitamin K, which we'll talk about next. The one place this could sometimes have an effect clinically is that warfarin users may see their INR level rise if they're taking too much vitamin E because the vitamin E begins to inhibit vitamin K in addition to the warfarin that they are already taking. The last of our fat-soluble vitamins that we'll discuss in this module is vitamin K. This is the structure of vitamin K on the top right of the screen. It has a long hydrocarbon tail connected to two rings, and it's very important for activating clotting factors in the liver. And the key word is activate. You don't need vitamin K to synthesize these clotting factors, but you need vitamin K to make them into their active forms. The vitamin K-dependent clotting factors include factor 2, 7, 9, 10, and also protein C and protein S. And vitamin K is necessary for post-translational modification of these factors into their active forms. All of the vitamin K-dependent clotting factors are synthesized as an inactive precursor, and somewhere in that precursor molecule there is a portion of the molecule that looks like the amino acid glutamate. This is called a glutamate residue of the precursor molecule. Within that glutamate residue, there is a carbon called the gamma carbon, and initially in the precursor form, the gamma carbon contains one carboxylic acid group. To become activated, this precursor needs to have a second carboxylic acid group added to that gamma carbon. This type of reaction is called a gamma carboxylation, and vitamin K is an important cofactor for that gamma carboxylation. Once the glutamate residue has been gamma carboxylated, it is now called gamma carboxyglutamate, or GLA, or a GLA residue. So what you will read in textbooks is that vitamin K is necessary for forming gamma carboxyglutamate or GLA residues on precursor proteins, and that's because you need to add this second carboxylic acid group to the gamma carbon on the glutamate residue. You get vitamin K from two places. One form is called the K1 form, and you get this when you consume green leafy vegetables. It's found in cabbage and kale and spinach. You can also find it in egg yolks, and if you consume liver, you can get lots of vitamin K1 from liver. The second source of vitamin K is called K2, and this comes from GI bacteria. They synthesize vitamin K and then secrete it into the GI tract, and you can absorb vitamin K from those bacteria. The most important clinical tie-in of vitamin K biochemistry has to do with the drug warfarin. Warfarin is called a vitamin K antagonist, and it is given in the treatment of blood clotting disorders. In order to understand the mechanism of action of warfarin, you need to understand that when those precursor molecules are converted to activated clotting factors via gamma carboxylation, vitamin K goes from a reduced form to an oxidative form. If you want to be able to continue to synthesize activated clotting factors, then you need to regenerate the reduced form of vitamin K. The enzyme that regenerates the reduced form of vitamin K is called epoxide reductase, and warfarin is an inhibitor of epoxide reductase. So in patients on warfarin, they cannot regenerate reduced vitamin K, and therefore they are less able to synthesize activating clotting factors, and this is helpful in patients who have blood clot disorders. The main clinical finding of a vitamin K deficiency is bleeding. This is often called a coagulopathy, and this is because you will be deficient in the active forms of the vitamin K dependent factors. The key lab findings are an elevated PT and INR. You can also see an elevated PTT, although this is less sensitive to small changes in levels of the vitamin K dependent factors. Importantly, however, you will have a normal bleeding time because platelet function is not affected. And I explain these blood tests in more detail in the modules on antithrombotic drugs. A dietary deficiency, you should know, is very rare, and that's because I told you that a second source of vitamin K is GI bacteria. So even if you don't get enough from your diet, those GI bacteria will usually produce sufficient quantities so that you don't develop a bleeding vitamin K deficiency. The main clinical scenario where you will see signs and symptoms of a vitamin K deficiency is among patients taking warfarin. This is the point of giving them this drug, so you expect to see this. These patients aren't actually deficient in vitamin K, but they have deficient action of vitamin K because all of the vitamin K is tied up in the oxidized form because you have inhibited epoxide reductase. Another clinical scenario where you can see a vitamin K deficiency is among patients taking antibiotics. The antibiotics that you give them to treat a dangerous infection can also decrease their GI bacteria. This means they will have less vitamin K coming from the GI tract. This can alter the warfarin dose in patients taking warfarin. So you give patients enough warfarin to counteract the normal amount of vitamin K in their diet and coming from their GI bacteria. But then if you wipe out those GI bacteria with an antibiotic, suddenly that warfarin dose is too high and the patients can develop bleeding or a very high PT-INR. Another clinical scenario where vitamin K deficiency may occur is among newborn babies, and that's because their GI tract is sterile at birth, so they're not going to get vitamin K from their GI bacteria. In addition, there's not a lot of vitamin K in breast milk, so there is a risk among newborn babies of dangerous neonatal hemorrhage if they don't get enough vitamin K from some other source. And for this reason, most babies are given an IM injection of vitamin K at birth to make sure that they don't develop any bleeding complications until a few weeks go by and they develop bacteria in their GI tract. The final topic I'll mention in this module is zinc. Zinc is not a vitamin, it is a metal, but it's a cofactor for more than 100 different enzymes in the body. In some parts of the world where children have very poor nutrition, they can become deficient in zinc and they will display poor growth. And importantly, they will have impaired sexual development. And a zinc deficiency is on the differential for children who have delayed sexual development. In addition, children or adults who are deficient in zinc can display poor healing of wounds. They can lose taste because zinc is required by taste buds. They can also have immune dysfunction because zinc is required for cytokine production. And finally, they can develop a dermatitis. They can get red skin and pustules. This is sometimes reported in patients who are receiving IV nutrition, which is called TPN. If you forget to supplement the TPN with zinc, one of the first signs you will sometimes see in chronically ill patients is a dermatitis. Zinc can be found in meat, especially in chicken. It is absorbed in the duodenum, similar to iron, and there are some risk factors for deficiency. These include alcoholism, and in fact, low zinc levels have been associated with an increased likelihood of developing cirrhosis among alcoholics. You are also more likely to develop symptoms of a zinc deficiency if you have chronic renal disease or if you have a malabsorption syndrome. Acrodermatitis enteropathica is a rare autosomal recessive disease in which zinc absorption is impaired. It's caused by mutations in genes that encode for proteins that are necessary for zinc transportation. Children born with this condition develop a characteristic dermatitis. They have hyperpigmented skin that is often red. Classically, it's in the perioral or perianal region. You can Google this online and see pictures of children who have this condition. They also get the dermatitis in their arms and legs. And then they have other symptoms from the zinc deficiency. This includes loss of hair, diarrhea, and poor growth. And they can have immune dysfunction that manifests as recurrent infections. There is a tie-in with molecular biology that has to do with zinc that they like to ask you about in step 1. This has to do with zinc fingers. Zinc fingers are segments of larger proteins that contain zinc. They're sometimes called a protein domain or a protein motif, and they are found as portions of larger proteins, and this portion of the protein binds to other proteins or to RNA or to DNA. Zinc fingers have been shown to have lots and lots of different roles in biology. They're often important for binding to DNA, so they'll bind to a very specific DNA sequence, and then they will influence or modify the gene and the gene activity. And this is a picture of a 3D representation of a zinc finger. You can see that zinc is in the middle of it, and this could go and bind to a bigger section of a DNA strand and activate a particular gene or deactivate a particular segment of that gene. And that concludes our module on other vitamins.